We are going to begin. Good afternoon, everybody. The webcast is about to begin. Please note that today's call is being recorded and all participant lines will be muted during this broadcast. And today's webinar will last up to 60 minutes and will include a specific question and answer session at the very end. So please make sure that you can enter the question in the Q&A box and press send so that we can help answer the questions. You can, of course, put in your questions at any time during this webinar. I am Supriya Jain. I'm the host for this webinar. I am a pediatric cardiologist and associate professor of pediatrics and radiology at New York Medical College and the director of pediatric cardiac MRI and advanced cardiovascular imaging at Maria Fareri Children's Hospital today. And it gives me great pleasure to bring this exciting webinar, which is hosted, and SCMR, the Society of Cardiovascular Magnetic Resonance Imaging, is pleased to present this webinar in collaboration with the Society of Cardiovascular CT, and in this collaborative webinar on how to build a joint CMR and CT program at your institution. And we have an amazing panel of experts with expertise in both CT and MRI. And it's presented by our SCMR's pediatric section liaison subcommittee members, which includes Puneet, Preeti, Lorna. Lorna will be acting as one of our experts. As the founding chair of the liaison subcommittee, it is very exciting to see this collaboration. And the goal of this webinar and this collaboration is to learn from each other, understand each other's perspective. We have cardiologists, radiologists. We want to hear from their experiences, tips. It is great. Number one, why do we need such a program? What are the obstacles? Is there a roadmap? And can we navigate this together with the guidance of our experts? So it's my pleasure to introduce our first expert, which is Lorna. She's a professor of radiology, University of Colorado, and the radiology director of cardiac imaging at the Children's Hospital of Colorado. Her research interests include 4D flow, MRI, fetal cardiac MRI, decreasing anesthesia, radiation, and contrast to pediatric cardiac imaging. Puneet and Preeti, if you can please introduce our two other guests.
Sure. Thanks, Supriya, for the opportunity to co-moderate this exciting webinar. My name is Puneet Bhatla. I'm a pediatric cardiologist and an associate professor for pediatrics and radiology, and the director of congenital cardiovascular imaging, the 3D printing and VR program, and the echo lab at the Hassenfeld Children's Hospital at NYU. It gives me great pleasure to introduce our next expert panelist, Dr. Kelly Hahn. Kelly is a pediatric and adult congenital cardiologist, a well-known leader in both MRI and CT. She's the Lloyd Taney Endowed Chair and a professor of pediatrics. She's also the director of non-invasive cardiac imaging at the University of Utah Primary Children's Hospital. Dr. Hahn's research interests includes assessing comprehensive diagnostic risk and accuracy of congenital cardiac imaging, establishing multi-institutional risk of CTA, and hopefully expanding this to multimodality imaging registry. Thank you, Kelly, for joining us today.
Happy to be a part of this.
All right, everyone, I'm Preeti Ramachandran, and I am an assistant professor of pediatrics at the University of Kentucky, as well as the director of pediatric cardiac imaging. I have the immense pleasure of introducing Dr. Cynthia Rigsby, and it's going to be difficult to keep this introduction short. But Dr. Rigsby is the chair of the Department of Medical Imaging at the Ann and Robert Lurie Children's Hospital of Chicago. She is also the Earl Frederick Endowed Professor of Radiology and Professor of Pediatrics at the Northwestern University Feinberg School of Medicine. So Dr. Rigsby is a nationally and internationally recognized pediatric cardiovascular imager with expertise in pediatric MRI and CT imaging. And she's been performing cardiovascular CTs since the late 90s. She has several peer-reviewed publications, is NIH grant-funded, and has several research interests, but currently is researching into application of 4D flow and rapid CMR imaging. So welcome, Dr. Rigsby.
Thank you for having me.
Okay, so to get started, just a brief outline for our audience. What we want to cover, hopefully cover in the short time we have, is number one, figure out why are we even talking about this topic today. is there even a need for such a joint program? Which initially we're going to talk about the need and an acceptance. To let you know, and I think many of us, including me, we were like, oh my God, CT, radiation concern, and which is, is the case, but maybe that's the discussion we want, an honest discussion. As CMR people who are probably more CMR trained, how do we start accepting CT? But we know that the CT, a joint modality, really helps in our complex congenital patients. And then we'll go over the roadmap about, what is needed. So once we all agree, yes, do we need one? Do we want something for our institution? Is there something which we need to look at, all the technical aspect, training gaps, and so forth? So my first question to you is, Cindy, could you tell us from your experience about the evolution of CT and why do we really need to start understanding that, CT would be helpful in our patient subsets, and especially in the complex congenital heart disease patients? What's your take on it?
Sure. I think to understand where we are today, it's really important to understand maybe a little bit about where we came from. And this month celebrates the first CT that was performed 51 years ago in October of 1971. It was a brain CT with an X-ray tube and detector that rotated in 1 degree increments for 360 degrees around the head of a patient who was in a rubber cap surrounded by a water bath. So that's how CT started. Slices had, believe it or not, 3 by 3 millimeter in plane resolution, were 8 millimeters thick. 2 slices took 4 minutes with a 7-minute computation time per slice and a 2-hour print time per study, and we read on film. So that's where CT started, and technology has evolved rapidly over the next 20 years, from single slice CT to multiple slices and multiple slices with a moving table, or helical CT. And that was in the late 1990s when really CTA became feasible. And the last 20 years have really been all about increasing image acquisition speed with faster rotation times, wide detector and dual source scanners, which have excellent temporal resolution, down to about 66 milliseconds, that can now be used to freeze cardiac and coronary motion at any phase in the cardiac cycle. There's been improved spatial resolution in plane for the most advanced scanners now that have in plane resolution of less than 0.5 millimeter. And decreasing radiation dose has certainly been a focus of the better detectors, faster scanning, and output parameters that now can be used to really achieve consistent effective doses of less than 1 millisievert in our youngest patients. And lastly, an important component of this is that there's now dose monitoring software that has allowed dose assessment first at the scanner level when you're looking and scanning the patient, at the institutional level, and allows parameter comparison across institutions to monitor dose parameters and establish reasonable reference dose ranges. And certainly there has been increasing use of CT, and for assessment of congenital heart disease, CT has a lot of great things about it. Anatomy is absolute on CT and really has been compared to surgical and other imaging findings. And so it's a fast technique, can be used in patients who are moving and breathing without really having any image degradation. And the main thing we all need to discuss, and I think that's going to be one component of this discussion today, is really where does it fit in the armamentarium of imaging modalities in congenital heart disease? And we want to be sure that we're all following the ALERA principles to promote appropriate use of medical imaging studies, including CT, in children with congenital heart disease while avoiding excess radiation exposure.
Thank you, Cindy. And so the same, almost similar question, Kelly, as a cardiologist, what's your take? When we cardiologists, we shy away from, radiation, right? So how do we put that in perspective that, hey, do we even need this for our patients? And what is the comprehensive diagnostic risk for these imaging modality? So if you can mention that to us briefly, please.
Yeah. So my path for CT actually came through MR. And so I did, a regular pediatric cardiology fellowship, did a 4th year in imaging, which really was echo and MRI. And I was in an excellent MRI program, but there's just times when CT, you couldn't get what you wanted. Either the patient, was really little, had a fast heart rate, had an irregular heart rate, maybe a metallic artifact, couldn't get the coronaries. And so I was right next to a really nice CT scanner. And so I really have never trained in CT. And so all of my training has been sort of clinical on the job. And I think it kind of is the 2 pathways we need to explore going forward, is like the radiology sort of fellowship pathway, and then also kind of the clinical practice pathway. And I was lucky enough to be in Minneapolis, where they had a great cardiac imaging program. And we really just started with the attitude of, we don't know what we're doing and we're going to do our best and learn from each study and do it better next time. And that's kind of the way we developed a program. And so we really would look at each study and sort of say how, look at the contrast, look at the radiation. And I think that, from my perspective, we've had a lot of focus on radiation exposure, which I think is a valid concern in the past, but I think it's not so much now if you use appropriate scanners and dose optimize. But for me, a lot of times we're looking at patients who have congenital heart disease or hemodynamically unstable. And I think that the anesthesia risk is something we don't talk about enough. And if you look at, doing MRI with anesthesia in a critically ill infant, the hazard ratio of an adverse event is increased. We also have gadolinium exposure, which has FDA safety alerts. If you look at the manufacturer database, there's been deaths from projectiles and that kind of thing. And so I think that for me, it's like, I think you should have every modality at the highest quality, so you can pick the test with the best accuracy at the least risk for the patient for each clinical indication. I feel like in the past, people have been very modality specific and siloed, and they're trying to make that modality work for everything. And I feel like the best way forward is to use the best modality for the clinical question and then the risk of the patient. And so I feel like for me, I trained more on the job. And I actually reached out to Cindy when I was starting and other, radiologists to try to learn from them what they were doing. Cindy came, to Minneapolis, and we got our dual source, and it's been a wonderful collaboration. And I think there's so much to learn at the intersection of our fields. And so I really hope that we can, break down the barriers between SCMR and SCCT and pediatric radiology and adult radiology and cardiology, and really focus on excellent care and providing the optimal tests for the patient based on the indication. And so I really came through cardiac MRI and sort of self-taught in CT.
Great. No, thank you, Cynthia and Kelly. I think we're going to touch base a little bit about the training gaps, which I think we all need to be trained to do a really excellent CT. And I think maybe we leave the question at the end, but I do want to hear from you, all three of you, in terms of what you think absolutely favors CT versus MRI, or what favors MRI and CT. And some of them, we may have to do a, multimodality imaging. But I think moving on to the next question, I know Puneet has a couple of questions regarding the technical aspects. So Puneet, if you want to go ahead with your questions, please.
Sure. Thank you, Cindy and Kelly. This was great. Clearly, CT and MRI complement each other, and when it comes to evaluating congenital heart disease, there's always a growing interest now to learn and build such a program. So the challenge, I think, I agree with Supriya, for some of us, especially from a cardiology background, is the lack of knowledge or training when it comes to the technical aspects of CT imaging. So I feel it would be good to touch upon some of those technical aspects. Maybe one of you can briefly talk about the various scanners that are out there. I know, Cindy, you touched upon it briefly. Which ones would be optimal to scan a diverse patient mix? We're talking about scanning babies to adults with congenital heart disease, and especially when we're trying to, offset the cardiac motion. Any preferences, and what is your take on this?
Well, I have worked on a variety, the variety, the gambit of CT scanners over the years, starting off with, multi-slice 16 and 64 slice, to volume scanners, to dual source, and now most recently, photon counting scanner. And, I think that, speed matters, the speed of the gantry, the speed of the table, this temporal resolution. So there's no doubt that as these CT scanners have increased in their gantry speed and their temporal resolution, the imaging and our ability to get good imaging improves. So I do think, the optimal scanners for doing cardiac CT are the later ones. If you go faster, you can reduce your anesthesia, you do get prettier images, and you have the opportunity to use lower radiation dose techniques, including sort of single beat acquisition modes. But I think that, a lot of people don't have the luxury of really getting to use the optimal scanner or picking the best scanner. So you sort of have to make use of really what you have, and understand how you can maximize the use of what you have in your own institution. And, I would say even with, the 64 slice CTs, you can get really nice pediatric imaging. You just really have to understand that you're probably going to need to use more anesthesia. You're probably going to have higher radiation doses than the later scanners, and that you may need to use beta blockade for coronary acquisitions, and really maybe accept that there's going to be some indications that you really can't do with that scanner. But I think the important thing is to understand how to maximize the use of the scanner you have, although there are extremely exciting vendor technical innovations coming into play. You know, we're at a new interface with these photon counting CTs.
Thank you, Lorna. This was very informative. I'm sure very useful for anyone who's trying to decide amongst the various available options. Moving forward, I think another important technical aspect worth discussing would be the use of various gating strategies, during these scans. When to use retrospective versus sequential, or when we can just get along with turbo flash mode. Can one of you briefly talk about these? When do you prefer one over the other? And what are the implications on the radiation dose?
Sure, I can just start talking a little bit about the gating techniques, and certainly we can get into details at another time, but just as a high level overview. First, there's retrospective ECG gating, which is the gating method that has been around the longest. And that is basically low pitch helical imaging, where the X-ray beam is on during the entire cardiac cycle. And therefore the radiation dose output from the scanner it can be the highest of any of the gating methods. In addition to that, during the cardiac cycle, the beam can be on some scanners, newer scanners, modulated over certain portions of the cardiac cycle to accentuate the ideal portion of the cardiac cycle, say for coronary imaging. And this is also the technique that can be used for functional imaging as the beam is on during the entire cardiac cycle. There's also prospective ECG triggering, which is basically step and shoot imaging. So a slice is imaged, the table moves, another slice is imaged, so step and shoot imaging. And for this technique, you use the R wave to trigger a slice with the beam on only during the optimal phase of the cardiac cycle. And therefore you're slicing the heart in a couple of acquisitions. So 2 to 4 axial slices usually gets you through a pediatric heart. This is really what I find the workhorse for coronary imaging in most patients, and in patients in particular with higher heart rates over 70 beats per minute. And there's sort of a secondary prospective ECG triggering technique, and that's available on dual source scanners, where you can use high pitch helical imaging in conjunction with ECG triggering prospectively. And so the high pitch helical imaging with prospective triggering is where the acquisition is acquired during one heartbeat. And this is, as I mentioned, available on dual source scanners. It's rapid table motion, offers likely the lowest dose of all these scans. And the acquisition on these is from cranial to caudal. Images are acquired in a slightly different phase of the cardiac cycle from top to bottom. And so you can freeze imaging. These scans are fast. You can freeze imaging such as the heart and coronary arteries with this. If the heart rate is suitable for it, you can target a certain phase of the cardiac cycle, say for coronary imaging in younger children, you can target systole, where heart rates are a little bit higher. This is our workhorse for most cardiac imaging cases. We use ECG triggered high pitch helical imaging for almost all of our cases, except for dedicated coronary imaging in higher heart rate patients.
Great, thanks, Cindy. I think helps us understand the merits and drawbacks of various options that are out there. And how they can be used to answer important clinical questions. Next up, I think we very briefly wonder if we can talk about the post-processing that you prefer, if any, on the scanner. Any specific post-processing you ask for from the techs when you're done with the scan? Do you ever ask for a thicker splice stack for ventricular function assessment? I've done it a few times. I feel it shortens the time of post-processing. Any other tricks on the scanner possibly to limit artifacts, if you want to touch upon those?
Well, I think that, a lot of the scanners that you purchase these days, they come with their own software, and some of the sort of the CT vendor software is very good. They all have, their own individual attributes. A lot of them will produce beautiful 3Ds, but maybe certain things that particularly for pediatric imaging, they may not really have good software for, like, for example, RV volumes. I think I've found universally pretty hard on a lot of the different post-processing softwares that I've used. So I think that there probably is a need for third-party software for advanced cardiac CT, certainly if you're going to be doing cardiac function. But I think the thing to do is really to learn what your needs are in your individual institution, really, before you start buying software. I think see what you can do with the vendor software that comes with your CT. And then to sort of see what the gaps are, and then to talk to people who are using these third-party softwares to see which maybe might be the best fill for the gaps in your service. We do 3Ds in every single case, and we do post-processing with MIPS and MPRs in every single case, and then we do a lot of endoluminal views. So we do push the 3D post-processing quite a bit. And that is partly because it is a great way to help me interpret the scans, but it's also a great way for me to sort of advertise what we do. I think that really good 3D post-processing can be a great advertisement and can increase your scan referrals. But I think I definitely do use them for primary interpretation. I think it's very helpful to have a 3D post-processing lab because the workflow in CT is different to the workflow in MRI. Getting the 3Ds done quickly so that you can interpret them and you can show them to people is very important in CT, and probably maybe more important than it is in MRI. And I think that also is the advantage of a collaboration between departments in radiology and cardiology to maybe justify the use of getting people to help you do post-processing, because it can be very time intensive. And I think that, if you look at both cardiology and radiology, there are a wide range of justifications for the use of employing special people to help you with your 3D post-processing, and it can save you an enormous amount of time.
Great, thanks, Lorna. I think that's very helpful. I think if that's all from the technical side, if anyone has a question, you can put it on the chat or question and answer box, and we'll take it to the panelists at the end. Preeti, you want to go to the next section?
Yeah, thank you, Puneet. So my question is a little bit more patient preparation related, which also falls under, the technical part of CT. And so, in most adult institutions, especially, when we're trying to do coronary imaging, heart rate control is an important component of that. So my question to the experts is, in our population, so in our pediatric patients, what is the need for, is there a need for heart rate control? If yes, with current generation scanners, if yes, how aggressive do we need to be? And what medications do you typically use? And also, are there any published protocols on how you approach this while you're trying to set up your program?
So I can take this one. So I think when I think about little babies, your cardiac output is your stroke volume times your heart rate. And so for the really fast heart rates, your stroke volume is low. And so even though the heart rate is fast, you don't get a lot of systolic motion artifact. And so I personally don't use any heart rate control in babies. And typically, if you're looking at someone where you want to see the coronaries in relation to the right ventricular outflow tract and kind of the general coronary, I think you usually don't need heart rate control. And you can usually see the origin and the trajectory of the proximal coronaries very well. I think the places where you might need to use beta blocker and, more respiratory controls, if you're looking at like a patient with Kawasaki's disease, where you really want to see detailed aneurysms, you're looking for stenosis or distal vessels. But I think for the vast majority of patients, when I first started, I used a lot more beta blocker than I do now. And now I pretty much only use beta blocker for older patients where you really need detailed coronary anatomy. For all the patients where you're looking for coronary relation to the conduit, I do not use beta blocker anymore. And for the babies, I no longer do either. I think the interesting thing with the heart rate is that, below 60 diastolic is best, above 80 or so systolic is best, but between 60 and 80, you really can have more variability. And with kids, even if you use a lot of beta blocker, you really can't get their heart rates down to where you want them to be. And I think one of the biggest things to decrease radiation dose and increase your accuracy is to actually image a little bit later and breathe them a little bit earlier, because they're always going to have a little bit of a bump with the heart rate with the breath in, and then the heart rate's going to settle down. And so what we often do for our pediatric patients is we will have them start to hold their breath when we see the contrast in the pulmonary artery instead of the aorta. And then that initial bump of the heart rate will come down, because the way that your scanner will dose the heart rate is if it sees variability, it's going to widen the acquisition window and increase your radiation dose. And so we typically will breathe our patients, if they can tolerate a longer breath hold, a little bit earlier. And so we usually use beta blocker in patients who need detailed coronary imaging, and I really don't use it much anymore in other patients. And we did publish our protocol that we used in Minneapolis for that. And we typically did, metoprolol 2 milligrams per kilogram up to a total of 50 or 100, depending on heart rate. And I know other people have used vasodilators, and I know Cindy actually published, I think, Esmol as well many years ago. But we typically will give an oral dose of metoprolol and wait, about 45 minutes and then scan if we do need heart rate control.
Yeah, I think that's fantastic information for all of us to hear. I think I'm also curious to hear about how you make decisions about which patients need sedation versus not. I mean, and especially in infants, how do you approach that decision making?
So we did our multi-institution registry looked at that, and about 20% of patients got some sort of anesthesia. Babies, you can bundle with a pacifier with 25% glucose, and you can almost always get the scan. I think, about 4 to 6 months of age, the kids get really wiggly, and they usually need some sort of sedation to kind of stay on the table. I think with MRI, we typically will use anesthesia less than 8 years of age. For CT, since it's such a short exam, we a lot of times, I had a great scheduler in Minneapolis, and she would call the families and say, do you think your child can cooperate with this? And if the moms and dads said yes, we scan kids as young as 6 who are able to cooperate with the breath hold and get great imaging. But I think it depends on the patient. And we, in Minneapolis, we did a lot more intubation, and here in Utah, we're doing more just kind of deep sedation, but free breathing because it's one heartbeat. And so I think it depends on the scanner you have and the indication in terms of how much to use. But for babies, we almost never use sedation. Above 4 months of age or so, when they're wiggly, we use a little bit of sedation to sort of keep them on the table. And then, I think that intubation, if you need absolutely detailed coronary imaging, but a lot of other things, kids can just be free breathing but sedated on the table. And above 6, most kids can cooperate without. And I don't know if Lorna and Cindy do anything different than that.
Similar. We go up to 9 months with non-sedation. So as long as it's not a coronary, anybody who's less than 9 months of age is automatically in a wake track. And we've been, that was maybe a little bit pushing the boundaries initially, and it took a little bit of getting used to for the technologists, particularly getting IV lines, and the chubbier 6 months babies. It's tricky when they're awake. But we've got there, and now it's very unusual for a baby that's less than 9 months of age to get any type of anesthesia, unless we're looking at coronary imaging. And then on the other side of that, we've probably gone a little bit lower as well. We go down to, certainly 3 or 4 if it's not coronary imaging and not breath holding. And coronary imaging, we've done 4 or 5-year-olds pretty successfully. It definitely does depend on the patient, the parents, a huge role in sort of decreasing any kind of anxiety. We bring them in a little bit earlier when they're that age, so we can get the IV in. And then give them a time to settle before they have their scanner, before they have the scan, so that they're not just getting their IV, crying, and immediately put into the scan. I think you have to sort of set yourself up for success. But I think there's definitely opportunities to really push the boundaries with doing these patients awake. But it is more involved. It's easier to use anesthesia, but I think that you can get great images in a lot of these these children with some effort.
Yeah, and I think having somebody call the patients and families ahead of time to explain what's going to happen is very important, because the anxiety of the parent trickles down to the anxiety of the child. And having a nursing staff that understands when the patient arrives what's going to happen really does calm that anxiety to, as Lorna said, sort of drop the age of sedation, push the boundaries of sedation down to the 3 or 4-year-old. If they'll actually lay on the table. With high pitch helical imaging, if they'll lay on the table, you can generally have a scan done. Maybe not detailed coronary imaging, but just for vascular imaging, certainly acceptable to do so. So pushing the boundaries is very important. And I think child life is also another component that all of us have, or many of us have access to in potentially bigger centers, but also in smaller centers, to really help these patients and families arrive less anxious and understand what's going to happen for their exam.
So that brings us to our next
Yeah,
point.
so over to Supriya.
And no, I'm sorry, I didn't want to, just in the interest of time, I wanted to keep on moving forward, but, it brings a great point that, we talked about a lot of this technical aspects and about patient-related stuff, but it all ties down to how well is somebody trained in CT. I mean, it's a great idea that, yes, we need to start a CT program, but if you're not adequately trained, are we doing more harm than good? And so I want, maybe Lorna, Cindy, and even Kelly, if you guys can tell us, what do you see as the training gaps? Because I think that's one obstacle. There are, we have differences in training between a cardiologist and a radiologist, and each of us are comfortable in our own area of expertise. And so how do you deal with this particular gap? And if somebody wants to start a program, how should they begin? If you can tell us about the resources, and again, are those resources geared more for radiology, for cardiologists, and how should we go about that?
Well, I think that both radiologists and cardiologists share the same training gaps in many ways. I think if you just even look at our fellowships, our fellows, our individual specialties have broadened in scope so much that the fellows who are coming through, they don't really get a chance to spend that much time in cardiac CT. So a lot of fellows are only at best maybe getting a glimpse of cardiac CT in their fellowships, whether they're radiologists or cardiologists. And, I would love if we could maybe get some more dedicated time for our fellows in this application, because, I think that CT physics is still pretty hard, maybe not as complicated as MRI physics, but I think to really maximize the use of your CT scanner, it's really important that you understand how to do that. And while the doses in cardiac CT have decreased, exponentially since I started, it's still the only thing that I do on a daily basis that has, the ability to deliver, a very tiny dose to a massive dose. And it's really where I dial, you put the dial on that, where you're going to finish up. So understanding how to dial it down, I think it's really, really important. I think that it would be great if there was sort of ongoing mentorship in cardiac CT, and certainly there's a lot of courses that people can do. What the courses lack in cardiac CT is sort of the ongoing mentorship. What to do when you have a really difficult CT case, or really even how to interpret a really difficult CT case. So we, myself and Cindy and a few others from the SPR side who were doing a lot of cardiac CT, we developed an observership program for cardiologists and radiologists who are interested in learning pediatric cardiac CT, where they spend some days at our sites. And it's pretty intensive, 3 to 4 days at our sites, where we go through live cases, we go through all our case library, we sort of set them up for success. So it's really anything they need, whether supporting templates, billing information, post-processing, things like that we talked about today already. We sort of give them a lot more, things to help go back to their own sites and bring to their chief, tell them what they need, and then provide this ongoing mentorship. So they do reach out to us and show us these difficult cases and show us interesting cases. And I think it's been really successful. I think both cardiologists and radiologists who've come to us have really appreciated both the intensive observership and then the ongoing mentorship that we provide afterwards.
Yeah, and I agree with Lorna. The other thing I'd like to add is it's the radiologist, the cardiologist, but the other people involved on the team doing cardiac CT are also just as important, making sure technologists are comfortable with the techniques. They're often the consistency between different radiologists and cardiologist teams coming in, in even the same or in different organizations, so important. And also having a physicist that's around to help optimize doses, work on technique, and look at doses across scanners is really important for any individual institution, but also looking outside your organization at other places to be sure that things are comparable between one organization and another. And I know that Kelly is working on some competency and education standards too, and probably can add some comments about that.
Yeah, so from a cardiology standpoint, I do want to reiterate, I think the techs are absolutely essential. I mean, you have a really well-trained cardiac MRI tech, like Jan and I worked with in Minneapolis, or Dave for CT. I mean, I feel like those people are like gold, because they really are the consistency among all the people. And I feel like it's a team approach. to these patients. There's so many things you're trying to keep track of in terms of the IV and the contrast and all these different things. And so I really think that it's a team approach to the imaging. As far as cardiology goes, CT isn't even listed as a modality in the most recent training guidelines. And so if you look at the 2015 Task Force training guidelines for advanced imaging in congenital heart disease, it lists, what you should do for fetal echo, what you should do for transthoracic echo, what you should do for, transesophageal echo, and for cardiac MRI and CT is not even listed. And so we have people, even from our program, in the last couple of years that did a 4th year of advanced imaging and didn't do any CT or MRI. And so I think there's a huge gap with pediatric cardiology training. And I would love to start a platform where pediatric cardiologists can kind of have standards for kind of beginning, advanced, and then expert level. SCCT in their most recent guidelines they put out for training, they have a minimal standard for performance of cardiac CT for adults. And I think that they say you're proficient with 50 cases, which I personally think that's not enough to be an expert level. And so what we really need to develop is a multimodality, multi-specialty, and multi-society platform for education for CT and congenital heart disease. It doesn't just do, this is the bare minimum, but this is like a high level, and have it geared towards pediatric cardiologists and then also adult congenital cardiologists. When you look at half of our volume in Minneapolis was adult congenital patients, because they have pacemakers, artifact, need coronaries in addition to congenital heart disease. And so I'd love us to develop something that's from neonates all the way through adult congenital, that's open and inclusive for pediatric cardiology and radiology.
Thank you, Kelly. So I think we have an important question which has been posed, and something which we're going to discuss. Preeti, do you want to ask about the collaborative working methods and reimbursements, both radiology, cardiology?
Yeah. So I think this is an important element to touch on, and I'm curious to see what our speakers think about this. In most large freestanding children's hospitals, the approach to cardiac CTs are typically in a collaborative fashion. But there are institutions out there, this may be more like small to mid-sized institutions or children's hospitals, which exist within a larger adult setup, where maybe the work is more RVU driven or revenue based. In those situations, how do you navigate the turf between, if there is a congenital cardiac CTA, how do you collaborate between radiology and cardiology without, again, stepping on anybody's toes? And, any recommendations from our speakers on this?
I can start with that. First, I think it's nice to find common ground in the patient, and considering the patient first, seeking out people who have similar interests. If someone, either radiologist or cardiologist, pediatric or adult, is interested in doing cardiac imaging, finding someone on the other side who may also be interested in making a program work and grow. One of the things that's important, as you talked about, that some smaller organizations and private practices, of course, are RVU driven. And that equation is very hard to make work in cardiac imaging. No matter how many cardiac CTs you could potentially do during a day, the limitation on time is important, and really the RVU numbers just don't add up to account for time. And so I think that one of the most important pieces of all of this is for the team to get together with leadership to say, that this should be a programmatic investment in people and in time. And therefore, the RVUs that come out of this, whether they go to the cardiologist or radiologist, you can't share RVUs, of course, but that people get their time allocated to be able to do a good job and put good work together. And it's the downstream revenue, of course, from the cardiac surgeries that really is the where the pudding is in this, because the revenue from CT is certainly not as great as the revenue from the cardiac surgeries. So investment and in the program from the cardiac surgeons and their buy-in to the program will be important at the leadership level as well. So having that team approach and talking to leadership about really trying to make the program work, even if the RVUs don't add up, is important.
Yeah, I would agree. I think that to really develop a good service that's going to continually be sustainable and expand, that collaboration is key to that, because by combining our knowledge gaps, we can really take better patient care. And obviously we should be really primary patient focused. And I think that when you do provide a really good scan in a really tricky patient, that all of a sudden your referral base increases dramatically, and you become known in the community, even outside of your own hospital. You may have other competitors in your city as being the pediatric cardiac CT place, and so you start bringing in patients who are going to come in for cardiac surgery who maybe weren't automatically coming to your institution to begin with. So I think it really is programmatic development, and that does come from leadership down. If everybody's vested in the fact that by developing this collaboratively, that both departments are going to gain, and ultimately that the entire hospital is going to gain. And I think also, you know, it's very important that it's not just really increasing our cardiac CTs, we also increase our cardiac MRI. Certainly, we've noticed in our own institution that, you know, cardiac CT hasn't taken away from cardiac MRI. In fact, both have grown in tandem. And, you know, by sharing our resources, we've been able to share our fellows, which has also improved our academic production, you know, which, you know, when you're busy cardiac CT or cardiac MRI, to have fellows that can help you with post-processing, dictating, case reports, you know, research. I think it's really important to combine those resources. And then, you know, as we said earlier, you know, for 3D post-processing, for scientists, for physicists, it's really, you know, a really good CT program has access to all of these things. And I think that individually our departments maybe can't sustain all of those on their own. So by combining resources to allow us to get the physicists, the scientists, and all the other things that can go into a big program, it's essential, you know, to combine our resources and buy into the fact that collaboration will absolutely ultimately lead to both programs growing.
Thank you, Lona.
Leadership buy-in and collaboration is the key word here.
Yes, I think, and I think when we're talking about, you know, about the joint multimodality imaging. So I think having all of these players build up both the CMR and CT. In the interest of time, I think we are now going to move on to our Q&A section. We have some excellent questions being asked by our audience. And so Puneet, if you want to help summarize some of the questions so our panelists can start answering them.
Sure, Supriya. Yeah, no, thank you. This has been such a great and informative session. You know, we talked about the importance of collaboration to a little of everything that is needed to build a CT program. So there are some exciting questions coming through. The first question is more technical. So using a 64-slice CT scanner for pediatric congenital heart disease for a non-gated acquisition, would you recommend adjusting the gantry speed to the highest to minimize motion artifacts?
Yeah, I can handle that if you want. Yeah, gantry speed has to be at the highest, and you pitch also at the highest to minimize motion artifacts. I think that's essential for if you're dealing with a 64 slice. Is upping the pitch and upping your gantry speed.
I think one of the questions, I think, Puneet, just so to tie into all of this is one of the dose contrast one, if you can ask. But people had this question, how do you utilize the CT, you know, trying to reduce the radiation dose when our congenital patients are getting multiple CAT scans, cardiac catheterization procedures, x-rays, and how do you tie in, you know, the utility of CT when you're trying to minimize all of this? And very briefly.
I can take that one. You know, I think the hard thing is that we don't have a way to compare cath to CT. So CT, you get a DLP, which is a dose length product, which is basically how much you gave for each rotation times your scan length. And when you look, there's several good studies showing that the dose is decreased 85 to 90% with the newer scanners and with education. And when we did our multimodality registry, our institutional registry, the average DLP for 1,000 scans was 30, which is less than a millisievert, which is a very low dose. But when you actually look, so there's a couple of articles that have come out, and a lot of them are in circulation, and there's some looking at cumulative dose in pediatric patients. And a lot of our patients do have a high cumulative dose, and a lot of it's from cath, but we don't have a way to compare CT dose to cath dose. But I think that if you look, the current dose of less than a millisievert for most scans in pediatric patients is the equivalent of 3 or 4 months of background radiation. And so I think when you look at the lack of vascular access risk and anesthesia risk and all that kind of stuff, I think CT is actually a minority of the exposure for current patients that are undergoing cath and CT. And so we looked at patients that were undergoing cath and CT for pre-Glenn evaluation, and the patients that had a catheterization actually had multiples more radiation than those who had a CT. And so I think that if you're looking at cumulative risk of radiation, I think that CT, if it's done with dose optimization, is less than a cath. And the other thing to keep in mind is that there's 2 articles that have come out recently showing that our patients have a much higher increased intrinsic risk of malignancy. And so one of them was in Lancet in 2012, and they actually, another one was in, and they showed that if you have IVF and a chromosomal abnormality, your relative risk of cancer is like 30 times higher than normal. And, and the ones that actually, the articles that showed a link to radiation, one of them had less than 5 millisieverts as a control group having no risk. And then the other one actually had a radiation dose range of 0.3 to 69 millisieverts per scan. And so I feel like what was used to predict cancer and radiation dose in the past really is not reflective of current technology and how it's used.
I think that being mindful of the cumulative dose is important. We might do a planned cardiac CT to plan for a cath procedure to reduce the dose during the cath. And therefore we can go very low dose on the CT to get pulmonary artery anatomy, arch anatomy, just to avoid a cath acquisition, which is often important. So offsetting one for the other probably isn't the right, approach. It's probably what do you need to do to plan for a cath? How can cross-sectional CT and MR imaging do that for you? And then how do all these modalities, if you keep an eye on them, and cumulative dose for each patient add up over time, which is important because the number of radiation emitting procedures besides chest x-rays that patients are having now is increasing. And it's certainly part of what we all should be monitoring for our patients.
So just quickly in the, we have a few more questions, which I think Puneet and Preeti want to ask, but on the same CT concern, there's a question that many of the questions can be answered by echo, but they often get requests by pediatric surgeons or, other referral ways to do a CT. And so if the CT is not necessary, how do you deal with this? And quickly from my side, I would say it's pure education. So if you make them aware about what is needed and what is not needed, I think if the particular question is answered, I don't think we need a CT, but please weigh in, the people can weigh in.
I can just really quick, I'm a pediatric cardiologist and there's tons of resistance to CT. And I think that a lot of times the surgeons are using it for the 3-dimensional planning. And so it's not that you don't have the diagnosis. We have a fantastic echo lab here and I think it's very accurate. But and especially the younger surgeons, like they want that 3D visualization to plan the complex repairs. And so sometimes it's not for the diagnosis, it's for the visualization of the diagnosis that scan is ordered.
I'm going to jump on to a quick question on contrast dosing. And so the question is that people dose contrast based on the scanner they use or the length of the scan to decrease streak. And other people dose contrast based on patient weight. What do you do / recommend?
Okay, I'll go. We've evolved our contrast over the years, and that's definitely evolved over different scanners that they've used, ultimately with the goal of reducing how much contrast that we're giving. Our current protocol is by patient weight, but also by technique. So I do use slightly different contrast solutions for my neonatal scans and also for my coronary studies. So, but it is ultimately based on patient weight.
Okay. There is another question, I think, which ties into something important that we were discussing before the webinar started. So this question says, what have you found works best in your programs for joint reporting of CT scans with cardiology and radiology? Should cardiologists be primary interpreters of intracardiac findings? And I'm just gonna kind of tie in with this question is the billing aspect and what your thoughts are from a billing standpoint. So I would be curious to see what our speakers think of this. We can start with Cindy, Lorna, and then Kelly.
Sure, I think that as far as interpreting exams go, and the way that we do it, and this may not be the best way, is we have a primary driver of a scan itself. So I may be that person, or one of my cardiology counterparts may be that person. We each work up the patient, understand the indications, do the scan and interpret it. And fully put a report in. And then we'll all sit down at the sometime during the day to review the images and make sure that we have input from one side or the other. If it's a cardiologist primary, then a radiologist adds input on from their side and vice versa. And at the scanner as well, like for image optimization technique, we all sort of talk about these things and make sure we're optimizing the scan from start to finish. And so when the final report goes out, it really is a product of radiologist, cardiologist joint interpretation, and having templates and to guide your reports is important, so that in the end, when the report goes out, it doesn't really matter if it's a cardiologist or radiologist that reports it. The templates are similar, and therefore you'd have to look at the line on the bottom to see who actually signed off the report, who the official sign is. But in addition to that, it's nice to also acknowledge the other person. So acknowledgement in the report that either a radiologist or cardiologist is a co-reader on it is important, I think, just for institutional comfort as to who is involved in these cases.
Sorry.
There's an interesting question. I'm sorry, if you'd like to continue, that's fine. There's an interesting question that I want to bring up after you're done. Sorry.
Oh, we do it the same as Cindy. So it's pretty much exactly the same as Cindy.
And just as a pediatric cardiologist, I think it's really important to have a true radiologist do the non-cardiac stuff, because these kids often have other anomalies that I think a pediatric cardiologist could easily miss. And so if you have a cardiologist reading the cardiac part, I do think it's really important to have a radiology addendum.
Okay, I think we have just time for one more question. Puneet, do you want to go?
Yeah, so there's this interesting, question that has come up in our program. I know that, the FDA has come up with these guidelines for checking thyroid studies after giving iodine-containing contrast in patients less than 3 years. What are the experts recommending? Do you routinely do these thyroid function tests in these patients, and when?
Yeah, so that was I can start with that one. That was an FDA recommendation recently, and there have been a couple of society sub-recommendations regarding the FDA recommendation, including by the American College of Radiology and the American Thyroid Society, ATS, I think, where limiting the thyroid function testing to a younger age group, potentially less than 3 months of age, may be more appropriate than the initial FDA recommendation, which is based on limited numbers of patients anyway. And so I think that right now, those are the recommendations that are out there. We in our organization have actually started working on a process, and actually we are about to launch it, where we will be, at the time of ordering of contrast, we will also be ordering the thyroid function studies through EPIC, and a BPA alert will come up when the patient is 3 months, after that, because you want to have testing within the window of 3 months. And so we'll order the thyroid testing. The patients will have it, and our endocrinologists will follow up on any abnormal results. It does take a little bit of an EPIC maneuver to make all these things happen, to make sure results are routed to the appropriate people that can handle the results, who are often not the people who actually order the contrast. So I think there's more to come from all of us on outcomes of this, and if this is going to prove to be a useful, if assessing thyroid function is useful after contrast in the long term.
Okay, thank you, everybody. I think we may have some more questions, but what we are going to do is we'll try to help answer this question post-webinar if we haven't answered it already. And we can, share the questions with our expert panelists so that, you can have a direct access to them. And then there was a question, Lorna, about how do pediatric cardiologists get involved with the SCMR observership? I think, you can let us know, we'll have a resource guide where Cindy, Lorna, Kelly, you can share with us, and we'll share the link on the website. So I think that concludes our today's webinar, and I think the take home points is this is a big topic. We can't cover all of this in one short webinar session, but there's so much more to learn. But a multimodality imaging program, I think, really benefits our pediatric congenital heart patients and SCMR and SCCT working together with and SPR, all the other professional organizations, I think we can help with the training aspect. But I think the most important part is being a patient advocate, trying to figure out what is needed for our patient. Does this modality of choice really work for our patients, then really going with the flow? I think that's really important for all of us to take with it. And you will soon be receiving an email from SCMR with links for the evaluation survey of this webinar. And please register for all our upcoming webinars at www.scmr.org. Just to let you know, there's another pediatric webinar, which is scheduled on November 14th with interesting cases. So please send your cases to Joe Pagano and me, and we hope to see all of you back for our future webinars. So thank you once again, Puneet, Preeti, Lorna, Kelly, and Cindy. This was a great discussion, and we hope to continue the conversation further. Thank you.
Thanks, everybody.
Thank you.
Thank you.